Let's discuss seating maxillary anterior veneers. This is a before and after case. Again, before and after. Lips in repose. You'll remember our video on lip position versus tooth position and the three different types of lips in repose. The flat lip, which this gentleman has, the moderately arched, which displays about half a tooth in repose, and the maximally arched lip, which displays almost a full tooth with the lips in repose. And you set the lip in repose by just going, lick the lips and go, and that's one of the ways we determine tooth position. So you can see he has a flat lip in repose. And this again is before and after we've restored the mandibular and maxillary anterior teeth. Veneers in place, pre-op. See a bunch of old yellow composites interproximally. Somebody just kind of patched him up. Lower veneers, close the spaces. Upper left side before and after, upper right side before and after. You see we've gone back to the first bicuspid tooth. When I'm placing veneers, it's always 2 teeth, 4 teeth, 8 teeth, or 10 teeth in the maxilla. Never 6 teeth and hardly ever 1 tooth, because it's so difficult to match the shade of one central incisor to the other central incisor, unless it was some old cowboy that just got off a tractor and it really didn't make any difference. And the same with extending. If you're going to change the shade of the teeth, you must go extend at least to the first bicuspid. There's not few things that look worse than a light hue-chromin value of the 6 anterior teeth and then yellow teeth posterior to that. So don't do that. And if you're doing 2 or 4, you must match the adjacent teeth. You're not trying to change the shade of the teeth. So these are the returned veneers on the stone model. The patient returns with the provisional restorations, and we have precisely determined the length of the teeth in the provisional restorations. It's very important that the laboratory technician receive excellent photographs of the provisional restorations in place, as well as study models taken, impressions taken and study models poured of the provisional restorations in place. Because what I'm telling him is this is a good length. Use artistic license, but this is a good length based on tooth length, lip position, lips in repose, pupillary line, all those things we've talked about. Provisionals in place. So this is sit and nest 4% plain, and I'll follow it with lidocaine 1 to 100,000 epinephrine. Now this is an excellent topical anesthetic gel. It's compounded with lidocaine, prilocaine, and tetracaine. Let that sit for about 30 seconds or so, and then spray it with Hurricane topical anesthetic gel, which is 20% benzocaine. We spray that on, and then I blow it in with my air syringe. Blow that into the tissue. And that'll probably penetrate maybe a millimeter or so, which is all I need to begin the anesthetic event. Will barely penetrate that tissue, and I'll lightly tap the end of the syringe and first use sit and nest 4% plain, and then follow that with lidocaine 1 to 100,000 epinephrine. Now we're removing the provisional restorations by cutting between the bisacrylate provisionals. This is just a real thin mosquito diamond. Just separate the provisionals. Then this is an elevator. Be sure you place the 2x2 in the mouth so one doesn't fall off and the patient swallow it or aspirate it. Just torque it and they'll pop right off. These were cemented, you'll remember, with unfilled resin. No primer, no etching. Just unfilled resin or adhesive. You just torque between them and they come right off. And rinse all the debris, but you shouldn't have very much penetration of the enamel with the adhesive. Then this is just pumice and water on a prophy cup. I'm removing any bits of debris. Now while the patient's in provisional restorations, every night they've been rinsing with mouthwash for a minute, then brushing the provisionals right at the gum line. Half of the toothbrush on the gum tissue and half on the provisional restorations with a Sonicare toothbrush or a mechanical toothbrush. And then finally, rinsing for a minute with chlorhexidine, in this case, Perigard. Then they spit that out and leave the excess on their mouth while sleeping. The next morning, if they want to just rinse with mouthwash, that's fine. So we're just removing any little bits of adhesive from the tooth, and the adhesive is not penetrated deeply into the enamel because we did not etch. Now this is a large bottle of lukewarm water. I usually don't use the air water syringe because there's too much power and it may elicit bleeding. Now with 2x2s in the mouth, to block it, I'm wiping the teeth with isopropyl alcohol. Again, just to remove, on a large cotton ball, just to remove any little bits of debris, adhesive that may not have come off with the pumice and water. So I'm just scrubbing those teeth just to clean them real well with the isopropyl alcohol on a cotton ball. Lots of 2x2s in the mouth. And then again, rinsing with the the large bottle with the large end of lukewarm water because we don't want to elicit any more bleeding than possible. Okay, so I'm trying these veneers in. Be sure they're wet and the teeth are wet. And this is just water in a dapping dish so that breaks the surface tension. Now if you use our study model technique that we've talked about in previous videos, you should not have to adjust the interproximal contacts. If you use the solid model technique. The solid model is used only for interproximal contact perfection. Be sure you've got 2x2s in the mouth because these can be tricky to handle. And sometimes I'll use the rope wax on a cotton tip applicator to place these, to try them in. So they're all tried in. Okay, so once we've checked the interproximal contacts by placing a finger on each veneer and pushing and being sure that the adjacent veneer does not move, then we remove the veneers and I'm wiping them with isopropyl alcohol on a cotton ball. The veneers have already been etched with 8% hydrofluoric acid at the laboratory for 1.5 minutes or 2. Following etching with 8% hydrofluoric acid, the lab places the veneer in an ultrasonic machine to remove the chalky layer from the tooth side of the veneer. It's very important that this is done. If you receive a veneer from the laboratory that has a lot of chalkiness on the tooth side of the veneer, that's not good, and they probably have not placed it in an ultrasonic. But I want the laboratory to etch these with 8% hydrofluoric acid prior to returning or sending the veneer to me. I don't have to re-etch it after trying it in because just once by the lab is enough. So now I'm just wiping the inside with isopropyl alcohol and drying that off just to remove any saliva or anything else that may have gotten on the veneer when I placed it on the teeth for trying. Then dry that off with your air syringe, and then this is just a cotton tip applicator with rope wax on the tip as a carrier for the veneers. I'm doing the same thing all the way back, wiping with isopropyl alcohol, then drying. Again, isopropyl alcohol, scrubbing and drying, and then placing, this is just red rope wax on a cotton tip applicator, and it's a perfect carrier. You don't have to press it very hard, continuing that process. So I lay them all out, ready to go. Then I'm going to wipe the teeth again with isopropyl alcohol, just as a double clean, and then etch with 38% phosphoric acid. And I want to, since all the preps are in enamel only, there's no dentin exposed, I can etch each tooth basically as long as I want to. Normally, I'll etch for 45 seconds if it's enamel. Now, another good thing about the 38% phosphoric acid that we've talked about in other videos is it's an excellent hemostatic agent. If you have any bleeding and you leave this 38% phosphoric acid on that tissue for 45 seconds, unless the patient is taking a lot of aspirin or blood thinners, the bleeding will stop. It's fantastic for stopping bleeding, but you have to leave it on that bleeding tissue for about 45 seconds and then remove it with ice cold water in that bottle with the large tip. You obviously don't want to remove it with your air water syringe or you'll stimulate bleeding again. So I'm going to etch these teeth for about 45 seconds apiece, and when I remove the etch, it's important that you remove it first on the first tooth you etched, because that one's been etching a little longer than the last one. I'm going to do 4 at a time, and then I'm going to suction that off, and then this is ice cold water out of our Ozarka machine. Then come back, do the same thing on the other side. Now, what if there was dentin exposed? What if the patient had a class 5 lesion? Then you're going to etch the enamel for 30 seconds, and then during the last 15 seconds, place the etch on the dentin. You don't want to etch dentin more than 15 seconds or the dentinal tubules will collapse and you won't create that hybrid layer that causes bonding to be so strong in the dentin. You can look at this tissue over here and see how any little bleeding like that has scabbed over. It was I discovered that by accident, but it's fantastic for bleeding. So again, I'm going to leave this on enamel about 45 seconds, but if there's any dentin exposed, which there was not in this case, don't etch it until the last 15 seconds of etching, and only leave it on the dentin for 15 seconds. In suction, then rinse with ice cold water, and look at how we've created hemostasis. So now I'm placing primer adhesive on the tooth side of the porcelain veneers. Do not cure the primer adhesive. I'm going to blow the primer adhesive off, and you want to blow it until nothing wiggles. That's getting rid of the carrier, which is alcohol. Alcohol is in the primer adhesive as a carrier for the primer. The alcohol is attracted to water in the dentinal tubules, and it carries that primer deep into the dentinal tubules. That's why we're going to leave the teeth completely wet when we place the primer adhesive on the teeth. But in this case, you blow everything off after you've placed the primer adhesive until nothing wiggles. Do this on each one, blow it off into a 2x2. While I'm doing this, all the lights in the operatory are turned off. The only light that's on is the overhead light, and I turn that down toward the patient's toes, so there's just a light glow over the tray. This tray is under the patient's chin, so there's no direct light on the porcelain veneers, which now hold the primer adhesive. We're going to blow that off, continue the process, and I'm putting these, once I've placed this, I'm going to put them under an orange screen. Just put it on there thick and then blow it onto a 2x2. And here it's placed on all of them, and then we put it under an orange screen, but there's still no light in the room. Now I want the teeth completely wet. Don't dry that off. Leave them wet, because that water is going to pull the primer down into the little mechanical parts of the enamel on the teeth. And now I'm going to apply the primer adhesive. I'm going to wipe it on, and that's going to displace all the water on the teeth. Use this same procedure when you're placing direct composites, say in an occlusal composite filling. Leave it wet, put the little pledget in the hole that's got plenty of water in there, and it will displace any of the water, but it leaves enough that it's going to draw that primer down into the little parts of the, and I'm sopping this on. I'm putting it on the teeth, just loading it on there. And then I'm going to blow the excess off here in just a moment. But this is very low light, as you can see, just putting tons of it on there, loading it on, and then I'm blowing it into a 2x2. Now be sure that you blow it into a 2x2 because you don't want it getting all over the patient's mouth. And I'll blow this into the 2x2 until nothing moves. Next, I'm using Rely X 3M porcelain veneer cement, and this is B0.5, and put the tip into the onto the two side of the veneer, squirt it out, and keep the tip in the material until you make a line right down the center of the veneer. Now, if you pull the tip out of the unset filled resin, you could create a void and there'll be a gray spot on your veneer once you seat it and cure it. How do I know that? I've had to cut one or two off in the past because inadvertently I took the tip out and captured an air bubble in this filled resin. If you do that and you have a gray spot on the outside of the tooth, you may have to replace that veneer. So don't do that. Now you'll notice we do not touch a curing light until all the veneers are seated. Do not cure the primer adhesive. Just blow it off, but leave it uncured until the veneer has been seated. So I'm placing each veneer on the tooth, and you'll see there's a lot of overflow of the filled resin, the luting composite. Don't wipe that off. Leave it on there. Then go to the next one and push these to place with the cotton end of a cotton tip applicator. Some dentists have said, why do you put them all on at the same time? Why don't you put them on one at a time? You don't want to do that. If you put them on one at a time, even with the wrapping technique we're using for our porcelain veneers that ensures precise seating, they may swim just a tiny little bit. And if they do, these perfect interproximal contacts that you've created by using a solid model will be lost. When you place the next veneer, if you don't try it in, that contact could be a little tight and the veneer not seat. That's one thing. The second thing is, if you place this veneer and you cure it, now you've got to remove at least the interproximal excess luting composite. Well, when you do that, you could mess with the tissue, and now you've got bleeding. Well, if you get bleeding on a tooth prior to placing the veneer, guess what? It contaminates the bond, and you may have a red area inside the veneer. So trust me, I've tried it every way. Seat them all together. But don't touch that curing light until you've seated all the veneers. 2 cotton tip applicators, one on the incisal edge and one on the facial. Now you remember I cut indentations or lugs in the occlusal facial of the bicuspid teeth, so I have a stop. If you've only prepped the facial surface of the teeth, you will hate veneers. You will hate them because you put them to place and there's nothing to stop them. They're swimming all over the place. So by one of the many reasons that wrapping is a good idea, you've included the incisal edge and the interproximal of the anterior teeth, and you have a lug or a cut into the occlusal facial of the bicuspids as a stop. So here we go, and I'm pushing, pushing, pushing. I'm not worried about anything setting up because the light's so low in the room. Then here's the red rope wax on the cotton tip applicator. Now each time I place a new veneer, I'll go back and push the veneers that have already been placed with the 2 cotton tip applicators. See, one's on the incisal edge and one's on the facial. Be sure that your porcelain technician really understands porcelain veneers and porcelain itself, and that he strums each porcelain veneer. What that means is the hemostats are holding the porcelain veneer. As he's stacking that porcelain, he strums the hemostat with a serrated instrument. It brings to the surface the water in the porcelain and water, so that the particles of porcelain are very close together, and it makes those veneers very strong. If he doesn't strum the veneer as he stacks the porcelain, there's a lot of water in the veneer, which is a lot of space between the porcelain particles, and guess what? Those veneers are going to be very fragile and very prone to breakage. I'm going back all the way around each time. A good way to remove that red rope wax. So once I've placed each veneer, I'm going to go back and push, 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 push with the cotton tip applicators until nothing moves. How much excess luting composite have I removed? None. Have I used a curing light? No. No curing light. Don't remove any excess cement. Then I'm removing just a little bit on the palatal of each of these veneers, just so I can see that margin and be sure that everything's in place. How do I ensure everything's in place? With this technique of removing a little bit on the palatal of each veneer, and then also looking with a large occlusal mirror at the incisal edges of these porcelain veneers and being sure that everything is in the arch alignment. Now when I remove this and I push the veneer to place one more time, the excess luting composite is just a little bit is going to squirt through onto the palatal. Then I'm pushing it again and it'll fill that void again and have a little bit of excess on the palatal so that the micro gap is filled between the tooth and the veneer. Why do we not remove the excess luting composite in the unset stage? I'm not removing any excess luting composite / filled resin in the unset stage. I'm not removing it until there's initial set, because I want this to break off and not wipe off. This is one of the keys to life, if you understand this about veneers. Between every restoration, there's a small micro gap. It may be 25 microns in a good restoration, all the way to 1,000 in a poorly made restoration. Bacteria is 8 microns. So if you wipe this excess off the margins of your restorations before it has initial set, some of that unset filled resin is going to pull out of that micro gap, and you're going to have a void in the micro gap when you cure it. Now if that happens, bacteria is going to get in the micro gap. You're going to get inflamed tissue, stain, possibly decay, and possible sensitivity. So don't remove it until it has initial set. So I've gone back and forth. You can see there's excess luting composite all over the place. So now we're testing one more time. Now I'm using my finger and on the incisal edge and the cotton tip applicator on the facial. Now I'm going back with the cotton tip applicators on incisal and facial. Key point right here. Defining moment with porcelain veneers. Don't do the dental thing. Many times as dentists will say, gosh, if a little's good, a lot's even better. Not here. I want to barely cure each of these veneers prior to removing the overflow or the excess luting composite. Now what do I mean by barely curing? It's amazing how fast these curing lights cure filled resin or composite. So this is how fast I'm going to cure the facial prior to removing the excess luting composite. I'm going to go beep, beep, about a little over a second for the facial of all of those veneers that have been seated. Then I'm going to go to the lingual. See, that fast. If you go any longer than that, you're going to have a hard time removing this excess luting composite. So now I'm going to chip that luting composite off, or it's going to break off with the back end of this scaler. See, so it's not rock hard, but it's hard enough, it's breaking off, and it doesn't pull any of that luting composite out of the micro gap between the veneer and the tooth. And remember, there's always a micro gap of at least 25 microns. So you want that micro gap completely filled with the luting composite. So it's like a sandwich, it's completely filled. If you remove any of the luting composite in the unset flowable stage, you'll pull some of that luting composite out of the micro gap, and you'll have a void, which leads again to sensitivity, red gingiva, inflamed gingival tissue, stain, and possibly decay. So this is soft enough to remove and floss. Now don't pull up on the veneer. I'm pushing through to the palatal with the floss. And don't pull up on the veneer with your scaler. You're moving with the veneer. Now what if you can't get the floss through in one area? You're going to take a very pointed, fine tip, 12 fluted burr, and just with no water, just cut through that luting composite that's filling the interproximal area between the teeth that didn't floss out. No big deal. See here, I've got an area that I couldn't floss, so I'm cutting that area with a very fine tip 12 fluted burr, and then you'll be able to floss it. But I'm not using any water. And see how each time I'm pulling the floss into the veneer, I'm not popping it straight back up. And this is the flat end of an amalgam carver, and in this phase I'm wiping it across the facial surface of the veneers to remove any filled resin or unfilled resin that happens to be on the facial surface of those veneers. This is an easy way to do that. So I've flossed each of them. See, this, the flat end just wipes right off. Now I'm going to come back and cure each veneer whatever you think is appropriate. I cure them 60 seconds on each side, 60 seconds with this curing light and 60 seconds with this one. You may decide that 10 seconds is enough. You can't over-cure. So especially veneers that have opaque in the veneer, and remember, I want to control the shade of the veneer with the tooth that is being veneered with the veneer, not with the luting composite. I don't want a translucent veneer and the shade of the luting composite comes flashing through that veneer, because remember, composite over time has kind of a dead look, not a real light refractive look. So I want to control the shade of the veneer in the body of the veneer. Maybe the luting composite will have a tiny effect on the overall hue, chroma, and value of the completed case, but not much. So in that situation, if you've got a bit of opaque in the veneer, I want to be sure it's completely cured. I used to use self-curing luting composite. That is scary because it goes through a gray phase. The other scary part is once it gets ready to set, it sets. And you may not be ready for it to set. So it's just too unnerving. This is a lot better to use the light cured filled resin luting composite, but just be sure you cure it enough, especially if you've got opaque in the porcelain. This is an Explorer, just checking the margins, flossing again. Now this is just a large chamfer, or it can be a medium chamfer, fine grit diamond. And I'm using that to remove the excess on the palatal side. Just very light touch, lots of water. Just remember, we have overflow filled resin on the palatal side. And I want to polish that until I can't feel the margin with my Explorer. Then I'm going to come back with a 12 fluted carbide burr sharp tip and just go around the sulcular part of the tooth on the palatal and into these interproximal margins to be sure the margin, that there's not any excess composite on the margin. I want those margins flush with the tooth so I can't feel a margin with my Explorer. Just light pressure, lots of water, sure all the excess is gone. Now you can use that same 12 fluted burr with lots of water on the facial margins, light touch. And if you do that, be sure you're going the direction that doesn't gouge with the burr. You know, one direction gouges with the burr, and if you go the other direction, it polishes. Go the direction that the burr is polishing that margin, just to remove any little bits of excess composite that may be on the facial margin. And more often than not, I do that. This is a Shofu rubber wheel. Now, you want to be sure that the wheel is spinning from the porcelain veneer to the tooth. You don't want to spin up into the veneer. And I like to drip water on the surface while I'm using the rubber wheel. So immediately after finish, checking the margins. I don't want to feel anything with my Explorer tip. This is really good occlusal paper. I've used this for 30-something years. It's very definitive, it's thin, and it marks wet. Then this is diamond polishing paste, 5 micron, lots of water. I like to mix it with water. Creates an ultra smooth surface, and just keep the water all over the teeth. Just drip it with your bottle of water with the large opening on the tip. This before and after, and here are the veneers in place. So there's no problem changing the shade, the hue-chromin value, as long as you restore at least 8 teeth. Sometimes, depending on the posterior extent of the smile, you must do 10, and some people even 12 if you want it to look beautiful. Incisal edge position with lips in repose. See, these should be the longest teeth. So I want this edge right here to be parallel with the pupillary line and the lower lip, and I want the incisal plane to blend seamlessly with the occlusal plane and be parallel with the lower lip. And this is his full smile. He's not a big smiler. That's the Dental Minute.
Hey you guys, I know that you were blown away by this episode of the Dental Minute, so go on over and press subscribe right now and get fired up, because next week we are talking about impressing and seating an implant crown. It's going to be awesome. We'll see you next week.